So, hi to everyone out there. As Puya just said, I'm Zara Patel. I am at Stanford University here in California. And, we were pretty early in this whole COVID-19 pandemic as far as the first people that were identified, the first patients identified were here in California in Santa Clara County, where Stanford University is. And so that is one of the reasons why I've become so involved in general in figuring out how this pandemic is affecting us as otolaryngologists and specifically as rhinologists, because that's my subspecialty. So we're going to talk about how this is affecting us as providers. And then, as Puya mentioned, I'm also going to be talking about how this may affect our rhinology patients, because we probably will be the people that see these patients most in the coming months. These are my disclosures. So, the data that we had very early on regarding COVID-19 and SARS-CoV-2. SARS-CoV-2 is what we call the virus itself, and COVID-19 is the disease process that occurs when someone is infected with that virus. And you can see here that a couple data points became kind of alarming at the very beginning when we started learning more about this disease process. So you can see here that an early New England Journal article in February was looking at the viral load in patients with SARS-CoV-2. And you can see that these two lines are from throat swabs and nasal swabs. And when you look at the nasal swabs, that was actually higher than lower down in the throat. So when we first started hearing about COVID-19 from China and from Iran and then Italy, the symptoms that we first began hearing were cough, shortness of breath, fever. It didn't really seem like we had to worry about too much up here. But studies like this one made us realize that even though patients may not be very symptomatic as far as congestion or a lot of drainage or sinus issues, they were harboring the virus in their nasal cavity. And you can then see, if you go to the next picture over here, that when people started to look at how long does this stick around in our environment, right? When we are walking around and sneezing and coughing and anything like that, where does the virus go and who needs to be worried about it? Well, if you look at that first chart on this side and look at the aerosol stability of SARS-CoV-2, you can see that the study went out to 3 hours. And that is why we know that aerosols can actually stay, viable virus can stay in the air for up to 3 hours. And just keep in mind that that's when the study ended. But we don't actually know. Maybe it's in the air for even longer than that. We just know up to that point that there is still virus in the air. So these two data points were kind of high in our mind as we entered into the phase here in the US where people began coming down with this disease. This was bolstered by some real world data too. So if you look at this diagram, this is actually from the CDC in Hunan in China, and you can look at this kind of trace contact from what happened when there was one individual who was an initial carrier who got on a bus. You can see they're the red person here. And then you can see all the people that were on this bus that became infected. And you can see how far away those people were. And what's most interesting is this pink person. The pink person was infected 30 minutes after that initial carrier left the bus, which shows us that either that person touched something along the bus as they were entering and exiting that the other person touched or coughed on or sneezed on, or there may have been, viral particles in the air. And so there is definitely, more to be said than just person-to-person contact as far as why the spread of this disease has happened so quickly and so widely. So then take that and think about, what do we know about the size of these particles? Because that has a lot to do with whether or not a disease process can be transmitted via what we call droplet transmission versus airborne transmission. And these things matter when we start thinking about the types of procedures that we do and how that can be spread. And so that's why I'm bringing this up. You can see here that what we can see, the smallest thing that we can see with our eyes is 40 microns. And then beyond that, you can see 25 microns is how big a white blood cell is, 8 microns is how big a red blood cell is, 1 micron is like a light dust particle, and then 0.3 microns are the droplets carrying the virus that are aerosolized in the air. And so we really need to think about what are the procedures that we do that could potentially aerosolize virus. So that is what brought me to this sort of realization in March. And, up to that point, I would say we really didn't think, about ourselves being on the front line for this disease process. Certainly emergency room physicians and intensive care unit physicians, all of the respiratory therapists, that made sense from what we were hearing about the symptoms and signs. But people like Puya began to contact me and tell me not only, are we seeing a lot of patients in our clinics who have these sort of vague other symptoms, but smell loss seems to be one of the maybe earliest signs, or sometime along the course of the disease process, a lot of these patients are complaining about loss of smell and taste. And Puya himself, as he's now told everybody, experienced that for himself. And so that was an early alarm bell that I got. And then add to that, I'll just tell you kind of the story of what prompted this first initial statement that we put out from Stanford and our skull-based group. My neurosurgeon and I were sitting together before one of our cases in the morning. I had just received communication from Puya about what was going on with the smell and taste. And then I received very troubling email from someone in our department who had contacts in Iran, Dr. Sajadi, who's also on this initial paper that we put out. His contacts in Iran were telling him that they were falling in the fight against this process, and that they were, not necessarily aware when they first began treating these patients or seeing these patients that they may be at risk. And unfortunately, sadly, one of the saddest stories in all of the otolaryngology world is a chief resident from Iran that was otherwise young and healthy, and then suddenly became ill and died. And that postmortem did confirm that it was from COVID-19. And now we know much more as time has gone by about how this can affect young, healthy people, even although the older people are more at risk. Certainly young people can be at risk from these thrombotic events that are associated. So at the same time I was receiving these communications, my neurosurgeon was receiving communications from his colleague in China and telling him about this initial super spreader of a patient who went through a Wuhan hospital after pituitary surgery, and 14 providers in that hospital became ill from COVID-19. And then he told us eventually about another case of another pituitary patient known to be COVID positive. At that time, they finally realized they needed more PPE, but not everyone had the same PPE. And in that case, one of the providers in the operating room wearing a PAPR that I'll talk about a little bit more, that they had made themselves at home, was safe and did not become infected. But 2 others in the OR who were wearing N95 masks did become infected. And then, so that raised questions about, are N95 masks even enough in particular cases that are high risk? So I tell you this whole story to sort of, introduce the environment that we all were in at the very beginning of this pandemic, where very rapid information and communication was happening. And we realized that here in the US, we needed to try to do something different than what had already been done in other countries to try to not only protect ourselves, but understand more about this disease process. And so we gathered all of this data and we put it out in this, what eventually became a letter in the journal Neurosurgery. But first was just simply circulated around the country and then eventually around the world. And I've heard back from many of you out there saying that, you were able to use that information to gain higher levels of PPE from your hospital administration and protect yourselves better. And I'm so glad that I and people like Puya were able to put that information out there so that otolaryngologists and neurosurgeons around the world could be protected. So having said that, the initial immediate effect that had on our clinics and ORs was sudden and great. And I think that was actually good. And we are now collecting data about, what is the number of otolaryngologists around our country and around the world who have been affected by this disease. And I do think that these types of procedures that were implemented early on here in the US may end up showing that we were able to protect more people. So, for example, right away after we realized the risk, in our clinic, we decided we would shut down and only see urgent patients, and all others were canceled at that time. All the patients then underwent screening questions before that visit, both before the visit at home and then again, as they entered the building, they were again asked those same COVID screening questions, got a temperature check. What's interesting about the screening questions is that has actually changed also over time. And we, at the beginning, like I said, the screening questions, even here in the United States, were simply things like fever, shortness of breath, cough, those very sort of classic symptoms that we relate to this disease. But, through some hard work and some communication and working with the CDC, we were able to finally get loss of smell and taste added to that list of screening questions that we ask here. And that has happened in a lot of other countries in the world, but yet there are still other countries, for example, the UK, that still has not added that particular symptom and sign to their screening questions. And so we continue to try to work with these organizations in countries around the world to try to encourage them to recognize this, because as you can imagine, the public, if they are not aware that smell loss is a sign of this disease, and they are otherwise asymptomatic, as many of these patients are, they will simply be walking around acting as vectors to other people in their communities and their families unless they know. And so adding this to a publicly listed screening questionnaire is very helpful in even in just preventing people from walking around and spreading it without realizing it. So the other things that we changed about clinic is that N95 masks and face shields were then implemented for all endoscopic examinations and procedures, because harking back to my initial slide talking about, this is highly viable in the nasal cavity. We know that the aerosol stays in the air for 3 hours, and add to that we know certain endoscopic procedures that we do create aerosol. Now the question, and what I'll get to at sort of the end of this, is which particular procedures. We don't actually know that. We don't have really good data, but we'll talk about that in a bit. The other change that we made right away at a teaching institution like Stanford is we immediately took out all of the visiting scholars, medical students, residents, and fellows from our clinics, because we really felt a responsibility to protect them as much as possible from coming into contact if that was not necessary. And as we were only seeing a very small number of patients, that we were able to do that early on. The change that occurred in our OR, and this has changed over time, and I'll get to what we're doing now, but at that time, early on, we again just simply canceled all non-urgent and emergent cases. We were lucky here at Stanford that we very early on had a PCR test developed here at Stanford University that had high sensitivity and specificity. And so we were able to test any of these urgent cases 72 to 48 hours preoperatively, and then have the patient self-isolate, self-quarantine until we were able to bring them in. If the test is negative, then again, N95 masks and face shields for everyone in the operating room, not just the surgeons, but the anesthesiologists, the nurses, the circulating people, the scrub techs, so everyone could be protected. And then if there was a positive test, we really tried at all costs to delay the case because we really did not want to have to expose everyone else in the operating room to that. But if it was not possible to delay, if it was a true emergency, then full PAPR gear was used. So let's just talk a little bit about what is PAPR and what is the difference between N95 masks and PAPRs, because this has been a question that has been brought up certainly here in the United States and possibly around the world as to, do we really need PAPRs? Is there any difference between N95 masks and this positive pressure air purifying respirator? And the short answer is there's not a lot of good data about that. But the three sort of things that are out there that do give us some data are from actually prior pandemics. So the SARS pandemic earlier in the 2000s, and looking at influenza virus and looking at other viruses. And when you look at these papers, this data, you can see that when you compare nurses or providers that were wearing N95 masks versus PAPR masks, and patients, this other study that had healthy patients that were wearing N95 masks or PAPRs and then exposed to an influenza virus, PAPRs do appear to be somewhat superior. Now these, are very small numbers of patients that were enrolled in the study, and so it's hard to make any definitive conclusions. But when you look at, for example, in that influenza study, when they look at 58 healthy patients that were exposed to that live attenuated virus, it was then detected in 3 of the 29 wearing the N95 and 0 in the people wearing PAPR. And so things like that might give us a little bit more information as to what is truly protective, but we certainly need more information regarding this. So that brings us to, what are the procedures that are most risky to us as rhinologists as we move forward? And there's this great initial study that Ben Blyer and the team at Mass Eye and Ear put together and put out that I thought initially might give us some information and tell us. And what he found, what they found by doing this was by using a cadaver head, a model, and doing certain procedures, for example, high-speed drilling, microdebrider, cold instrumentation, they found that aerosolization definitely occurred more with high-speed drills, which logically makes sense, right? We expect that to be the case. However, when we think about what they were truly looking at, their detection method could really only see particles down to a size of 5 microns. So if you recall, this is what I just showed you at the beginning, right? So when we think about 5 microns, that is nowhere near as small as the particles that we are actually concerned with. And a droplet of 5 microns is really in that droplet range and not in the aerosolized particle range. It is less than 1 micron that is truly those particles that stay in the air and never settle through their weight. And so the answer again at this juncture is that although this was a really great initial step in trying to figure out what are the procedures that may be higher risk versus lower risk, we still don't have the answer as to what exact procedures are aerosolizing mucus and possible viral particles into the air, because that is what really needs to dictate everything that we decide about, do we wear no mask, a regular surgical mask, an N95 mask in this particular procedure. And then it also dictates, when we start opening up our clinics, how fast we can turn over those rooms for a new patient to come into that environment, right? So that brings us to the current situation. Now we are slowly reopening because, as many of you may have seen, California has actually done a really good job of sheltering in place and flattening the curve, and we were able to avoid the very sharp peak that places like New York and Italy saw. And so by doing that, we are now going to slowly reopen. Now, we have to figure out, when we reopen, is this going to create a second peak, right? That's always possible. But What we're going to do now is we're opening our clinics with limited schedules, still seeing patients that are high priority, about half the number of patients you would see in a regular clinic day, and really only 1 day per provider. So I would say I'm about to start seeing about a quarter of the normal patient volume that I would usually see in a week. I'm going to be seeing in 1 day a week. We're still doing those same screening questions and the temperature check. We're still using N95 and face masks for endoscopic procedures. Now, the question in our minds is, like I mentioned, what is the risk, not only to ourselves, but the patients that we're bringing into our clinics after we do endoscopic procedures, right? Not only just from a procedure like using a microdebrider or doing a biopsy, but what if we're just suctioning? What if it's simple as a debridement, or they have mucus that we want to see around? Is that going to create aerosolization? Because when you guys look, I encourage all of you to go look at what the suction canister looks like in your clinic setting. I had this idea in my mind that there was a sort of intact, protected tubing that went somewhere and took all this away. But really what it is it goes into this bucket, and then there's an exhaust valve on that bucket that allows the air to escape. And in most clinical settings, that simply is just escaping into the cabinet that you're keeping your suction canister in. And that's not actually protected at all in any other way to the rest of the clinic room or environment. And so we really have to start thinking about how to prevent things like that from happening. And probably the best way of doing that is to place a HEPA filter. And there are some suction canisters out there that are that have HEPA filters in place within them, and we probably will eventually slowly switch over to those. We also right now are placing HEPA and UV filters in specific rooms where we know procedures are going to take place, and that is to filter and turn over this room so that we don't have to wait so long, like 3 hours maybe, to get a patient in. We can just wait as fast as that air can be turned over in that room, and then we'll be able to get someone in as long as all the surfaces have also been cleaned. So that's our current plan and goal right now in clinic. But again, this is such a rapidly changing thing, and I'm sure that this is also going to change in the next month or two as we figure out more. In the operating room, we are reopening to all elective cases. So actually, after I finish this this session with you guys, I'm actually going to be going to the OR to start my first elective case. And what we're doing, again, N95s and face shields still for all endoscopic procedures. We are now lucky enough at Stanford that we can get the PCR test 72 to 48 hours prior. And specifically for these high-risk endoscopic sinus and skull-based procedures, until we know more about what truly aerosolizes particles, we are also getting a rapid test the morning of the surgery. So again, the same thing, if they test positive, we delay if at all possible, but if we need to proceed to either save their life or an organ, we would use PAPR. So, this brings us to the smell and taste part. And, this is a publication that Puya is a co-author on. And I just applaud him for spreading this information very early on about the association. And, now there are multiple publications out there about this link. And, the idea that it's interesting because in different countries, there appears to be different percentages of the population that are involved or that have this associated. So for example, in China, it was only 5 to 6% of the population that they found had this associated symptom. But in South Korea and then in other areas in Europe, like Germany, it was, starting to go up to 30%. And then in some countries, it seems to be almost 60 to 70% of patients that have this associated factor. So I think that that's going to be the next interesting thing to study, that as we know, there are certain different strains that have come out in Europe versus the US versus Asia, and that may have something to do with why there is a different amount of olfactory loss associated with the COVID process. So this is another recent article that's come out, and this is the first article that actually used objective smell testing. They use the University of Pennsylvania smell identification test because Dr. Doty is the one who invented that test, and he uses that at pen, and we often use that in the US. And they found that even with objective testing, a very high percentage of patients had this association. And as many of you know, this is important because subjective olfactory loss often does not correlate very well to objective findings of olfactory loss. But this paper now confirms that even on objective testing, a majority of patients do have some some amount of smell deficit, even if it's such a small amount of deficit that they themselves do not realize that they are having that symptom. So definitely something to look for as we gain more information about this. Now, that brings us to, well, what do we do if a patient has post-viral loss? So I and, Zach, Justin, and Eric, all friends and colleagues of mine here in the US, we realized that, even before COVID-19, they were not everyone in our ENT community really understood what the things are that we can do to help treat post-viral loss. And so we put together this primer, and it's not just for COVID-19, although we do speak about specifically treating COVID-19 patients. And so I'll just give you a brief overview of the high level things, the things that have high level evidence that we treat post-viral loss with right now. So I would say the number one thing that we do is something called olfactory training. That actually has randomized controlled trial evidence, multiple trials now, that show that, just a structured smelling protocol, that's what olfactory training is, can improve probably 30 to 50% of patients over just placebo. And so really all it is taking a scent. We use essential oils and we have the patients smell it. It doesn't take a long time, just breathe in and out. We make sure that they're doing it with a variety of different odors so that they're stimulating different types of olfactory receptor neurons. And what we're really trying to do is switch back on that inherent regenerative capacity that the olfactory system has that is unique in all the other cranial nerves, but that a viral insult can damage and break. When you're doing that, what we can also add to that, and I'll talk a little bit about whether we do this in COVID patients or not, but in general in post-viral loss, I did a study showing that budesonide irrigation, so steroid irrigations in a rinse bottle, were actually very helpful also, added to the benefit of olfactory training. Now, we know that steroid sprays that just reach kind of this front third of the nose and then go down your throat, those are not helpful. Those have been shown in multiple studies to not be helpful for olfactory loss. But when you put the steroid in an irrigation and really bathe the entire nasal lining and sinuses, that can be helpful. Now, the question becomes, what about COVID-19? Because we know that, when people ingest steroid, although there's a lot of sort of conflicting data and we need more data about this also, but in some cases there have been reports that cardiovascular and pulmonary processes going on with COVID-19 patients worsen when they are given steroids. And so obviously oral steroids, if you see a patient early enough in post-viral loss, is something that we often treat people with, but we at this point, we're still collecting data, and Puya and I might be putting something more definitive out about this soon. But at this point, I would not recommend people give oral steroids to treat this post-viral loss in a COVID-19 patient, even if you think that they have recovered from their other symptoms, because it does appear that that could worsen this disease process. So having said all that, there's a couple other things that we know to try, but have different levels of evidence. So for example, I did a study using omega-3, but it wasn't in post-viral olfactory loss patients. It was in post-surgical olfactory loss patients after endoscopic skull base surgery. And so although, I do tell my post-viral patients about omega-3, I always add that caveat that it has not been studied in that patient group. And so we're really extrapolating data. And so we don't really know, and we need to do a study, and we probably will be starting a study looking at that soon with Dr. Hamel in Germany. So finally, other things like, for example, alpha lipoic acid, that has some good data, but it also has some conflicting data. And so it's hard to know. There's a whole host of other things that we could talk about that have data back and forth, and other things that people have tried out there that used to be in vogue, things like zinc or theophylline, that we now know do not help and could possibly be of detriment to smell. And so I would encourage all of you to only use those things that we have high level data for right now, and just do more research so we can gain more information about this. So finally, just to keep in mind, our typical sinus patients, the bread and butter of rhinology, these patients are probably ones that we also have to worry about, because as we know, many of these patients have associated pulmonary issues, asthma, aspirin-exacerbated respiratory disease, cystic fibrosis. These are the patients that we, even before COVID-19, saw in our clinic and realized that there was a complex interplay between what was going on in their sinuses and what is going on in their lungs. And this is going to be complicated by the presence and prevalence of COVID-19 in our environment, because we have to be cognizant of how patients who may be suffering from sinus disease that may be worsening their pulmonary disease process, maybe we are going to start thinking about treating their sinus disease differently in order to help them protect themselves from this virus. So I just want everyone to sort of start thinking in that way as well. So then how do we move forward? And this is, I'll just end with this and then open it up to questions. But, what I sort of see moving forward at this point in this pandemic, I think, number one, we really need a lot more data about all of this stuff that I've talked about how, what are the procedures that are risky? What are the PPE that are going to protect us best? What is the best thing for our clinical environment and our OR environment? The other thing that's happening, which is great, is that antibody testing is becoming more and more available. As this becomes more and more available, and hopefully we'll be able to decrease the false negative rate and false positive rate that is currently there for antibody testing, we probably will know a lot more about immunity going forward. If people have had the disease and then they recover, what does that mean? We currently have no idea. Does that protect us from getting sick again or not? Hopefully it does, but we really have no idea right now whether this is temporary antibodies, how long those antibodies may last. There have been case reports of people testing negative and then testing positive months later. And we really don't know what that means, because the PCR test only tests for genetic material. It doesn't necessarily tell you how viable the virus particles are. And so we just, again, need more data about that. But the good news, as many of you probably heard in the news yesterday, remdesivir from Gilead has been shown to be effective in preventing patients early on in the disease process from worsening and shortening the overall disease process to recovery. And, again, more data is needed for even this drug and other medications that are probably going to come out onto the market that are similar. But this is a sort of silver lining that we can see here coming behind the cloud, that this is at least a virus that we do have something to fight against with. And then slowly but surely, we're going to see a reopening of society because of the huge socioeconomic impacts that this has had on all of our global economies. And that is going to probably bring hope to people. And eventually, maybe not this year, but hopefully the next, I think we will end up with a vaccine. And as soon as that happens, it'll probably be life getting back to normal. And so with that, I'm happy to take any questions and talk with anyone about comments they have. And I'll just leave this up there if we run out of time, or if anyone wants to contact me on Instagram. I'm not that active on Twitter yet. I just got on this month to just post some articles, but I'm on Instagram at least. Okay.
You're doing pretty well, and I'm very glad that you proposed that, because I'm always telling everyone that in cases that we are going to be late, they can contact you directly for question and answer. So we do have questions from the application, from Facebook and YouTube and others. Before that, I have questions, and I would like to raise opinions regarding that. Yes, as you said, the antivirals are being tested and looks pretty good. However, this is going to be something that we have to take in mind for future, as you said, for vaccines. One thing that I would like to stress more and more right now is the few studies are coming out on really on opinions on ACE2. I do also think that working on the trials that has been proposed for chloroquine and azithromycins, all of those seems causing also some heart failures, of course, because of the association with heart diseases. I do think that we have to think about two different proposals if we want to address our therapies on the innate immunity or innate system, or if we want to go forward and discuss treatment in the second part, when the how to say, the B cells starting to act. If we want to work on that, like plasma or whatever it is, or
Right.
if we want to work on the interleukins, interferon gamma, which is completely differing, as you said, the things that causing the major problems are basically on the first steps, when the interleukin and all the cytokines starts to causing the huge immune response, and that will
Right.
cause the heart diseases and failure and the lungs, and that because and that will cause the fibrosis on the lungs and pneumonia and stuff like that. So we do have to think, if we wanted to work on that on the first period of the or the first days, and which is the critical stages where the people are asymptomatics and we don't know how it's going to work, or after 17 days. And this is basically the main part that we have to considering. And what changed in the last 2 months is that as soon as we developed and took in consideration using the appropriate, as you say, the DPI or protections, the whole thing has changed a lot, and the people are not going in the ICU, and the cases are dropped down. So
That is
by
excellent.
and by saying that, we start with the questions. The first question from our colleague Tibor is, what is the policy of oncological surgeries in your department? Is there more or less probable that the pandemic at some level will stay with us for months? Do you delay them for not? If possible, can you answer? And this is from Hungary. So I
Yeah.
can
Go
you
ahead.
reply on that?
Yeah, sure. So, at least here at Stanford, obviously, cancer doesn't care that there's a pandemic going on, and it just continues. And so, of course, we continue to treat our cancer patients. And so, cancer is really one of those things that we have deemed that sits in that urgent category of cases that do move forward. Even when we were completely closed down for everything else, cancer cases were moving forward. Obviously, making sure that everyone in the operating room had the appropriate protective equipment when they were doing cases like that. But yeah, there are certain things, cancer, and then, for example, in our skull-based practice, there are still patients that come in with a sudden loss of vision because there's been a bleed in their pituitary tumor and they have had apoplexy, and you cannot delay that case if you really want to save their vision. And so certainly cases like that, we're still moving forward even during the shutdown, because obviously you don't want to risk either life or organ or limb. Those types of cases were approved to move forward.
Another question that I'm also selecting few of the questions. We cannot answer all of them. So the second question to Katerina, she say, how is the setup of your clinic? Where do you do or don't? Do you take history and scope examine on a different room or by phone? How many nurses, assistants do you need for each section? Yeah, of course. I think that you proposed something like that, and you can answer clearly on that.
Yeah, so the sort of setup I described, but then what I didn't mention is that certainly during this time we have been doing telemedicine also, so doing video visits. So there are particular patients that are more amenable to that sort of visit. We have our hands tied a little bit in ENT because we're so procedure heavy as a specialty. And so, you know, I usually scope every single patient that comes into my practice to see what's going on in their nose and sinuses. And so not being able to do that on a video visit was frustrating. And the other part was that imaging facilities were also only doing urgent or emergent cases. And so if you felt like you wanted a CT of their sinuses, you couldn't necessarily get that at that time. But now, as we're reopening, you know, again, we're able to get CTs. And, you know, as far as in the clinic, in person, we're not planning on doing any sort of separate space for doing the history and then the exam, simply because we as providers are going to be completely protected the entire time that we're interacting with the patients. And so, you know, we'll bring them in as usual to the exam room. Our medical assistants who bring them back will also have protective equipment on. And then what we're really doing is still just limiting the number of people. You know, at a place like Stanford, we often have 4 or 5 visitors that are coming into the room with us and seeing how we do things, but that's not happening right now. Certainly we are limiting, you know, the number of people that are exposed to one another. And so all the history and the exam, the physical is all being done in one room. Now, I did mention that we have added these HEPA and UV filters, but we don't have those in every single room. And so if we know that we need to perform a procedure for a patient, so for example, if I'm going to do a debridement after I've done a surgery, then I probably will have that patient specifically roomed in the room that has the HEPA filter, so I can take that extra layer of precaution.
Yeah. I like the idea, and we don't have that. The separate two rooms, like a box inside of the box, which is it's a pretty good idea.
Yeah.
Yes, of course we're facing this huge problem. So we in Italy are beginning the phase two. With phase two, it's something that is not very clearly. I do think that the phase two is established on an economical issue, not on a scientific uh, statement, which is completely different. The thing that I would like to stress is the main the main thing that is happening is the collaboration and cooperation of different societies. I'm very glad that I had the opportunity to interact with people like you, with Claire Hopkins, with people around the world that accepted what I've said, and they were, already collecting data on that and try to push for societies and interacting with the administration that are not, interested to learn more from us and to adapt themselves. I think that ENT and rhinology especially are one of the specialists that are more confronting or facing this emergency, and we do have to completely change our methodology. What is going to happen in the next future? Because we are, for us, an endoscope was a normal tool, and we were able to use it every day. But right now, we have to face the emergency and to change our attitude. And regarding to endoscopic procedure, is one of the question over here. I think that we have space for other two. Is have you seen complication in COVID-19 patient like severe epistaxis? How do you manage do endoscopically? So do you have ever faced emergency like that?
So, so thankfully, no. We haven't had any sort of life-threatening epistaxis come in that was COVID positive. We have had patients who we know about that were in the emergency room, packed by the emergency room physicians, and they were stabilized. And so we did not, need to do anything further. But again, I would say in a case like that, if you did have a known COVID positive patient that was having an emergency bleed or really any other kind of emergency that you needed to perform endoscopy and manipulate the nasal cavity, you should just, make sure that you have the correct PPE, at the very least, the N95 face mask and the face shield if you're, coming towards them in the emergency room. But if you have PAPR available, that probably would be the best. Now, this is a sticking point for a lot of people, even, you know, at major institutions here in the United States. Some institutions only have a handful of PAPRs, and so they're not highly readily available. It's not like we have some surplus of PAPRs going around. And so that may be difficult, but if you're not able to get a PAPR for a COVID positive patient that you need to do a high risk procedure on, then at least protect yourself with an N95 and a face shield.
Last questions, because we're gonna be out of time, and you have your clinics, of course. I like the idea of this last question. Would you recommend patients pre and or post endoscopic sinus surgery to put in a negative pressure room or have an HEPA filter?
So, so that's a good question. I think that, you know, outside of the actual OR, once the aerosolizing procedure has completed, it's not like we think those patients are going to themselves be aerosolizing a bunch of particles into the air. And so I don't necessarily think that people need to, you know, go into a recovery room that is negative pressure or anything like that. And especially because in our case, we're getting 2 negative tests before we're proceeding. So we are pretty sure that these people are negative anyway. I will say that, you know, one other thing to consider, speaking about postoperative things to consider in our patients, is that there are some reports that just having surgery in a COVID positive patient may worsen their outcome. And so, you know, you have to keep in mind that, especially in places that are only getting 1 test, and that test may have a higher false negative rate than you'd like, you really should still keep in mind, you know, is this definitely worthwhile doing the surgery? Is it worth putting the patient at possible increased risk if they are an asymptomatic, unknown COVID patient?
Yeah, and that's the question. And last, it is mine, and it's a thought. We are going to, of course, see emergency procedure for oncologic patients that are positive on COVID-19, which means their immune system is completely changed right now, and we have to treat those patients because they're scheduled for cancer or whatever it is. So what you said is exactly the point. Can we guarantee those patients that everything are going to be like previously announced to them? And how, or do we have to change our informative or consensus that we put into those patients? Because of course, you know, legal issue is something that we are facing every day, but right now, everything class action or whatever comes in the next future, we have to be prepared for them. So the balance between, you know, healthy and legal is coming, you know, completely changing. Do we have to consider ourselves and not only the patient right now?
Yeah, I mean, I think that you're exactly right that we do need to change the way that we perform informed consent for patients. I think that even cancer patients, even people who, in our own minds, it's obvious that we need to move forward and we need to operate, otherwise they're going to die. We still need to include all these new risks that we are starting to learn about in those informed consents that, you know, even in the best of times, without a pandemic going on, when people are immunosuppressed after treatment, they are susceptible to many things. And in this particular time, they are even more at risk. And what that means as far as their own health and whether they're going to be able to interact with their family members in the same way, if they become close to the end of life, what that means for who they can be around. All of those types of issues are things that we need to begin to think about more clearly, and definitely, I think, change the informed consent process based on that too.
Yeah. So thinking in mind this, we really have to think about the future. We have to think about our patient, of course, but also we do have to take care of methodologies and how those will change in the next future. And the only thing that I would suggest is to keep in mind that science comes first. Newspaper are spreading like crazy stuff. Even our bureaucracy or politician are saying crazy stuff, that unbelievable things. And I
No one crazier than ours.
so I think that of course we have to adapt ourselves, but always taking in consideration what we're doing. So by meaning of that, I would like to thank you very much for your participation in that. I was sharing right now one of the leaflets that we published. This is the change that we have from your previous talk, with what completely different was the therapeutic options for treating patients with olfactory loss. I do believe, and I want you to be once again part of, as a guest for our international meetings. I would like to invite everyone for the next one, which is going to be for the 15th of it's going to be a Friday, May. It's going to be an ARS junior panel, American Rhinology Society junior panel. We are going to have 4 different speakers. Andrew Tambo, which attended also the meeting right now and is saying hi to everyone. And thank you, Zara, for your participation. Good luck for today. And I just want to congratulate you for your efforts during those few weeks, because everything happened very quickly and you were like smart like this. And I'm
That's
very
right.
glad that you participated. And I wish that everything will change and stop as soon as possible, and to see you personally in one of the ARS or ERS meeting over here.
I hope so. I hope that we get to see each other in person soon, and that everyone out there stays safe and healthy, and that I'll get through this together. Thank you so much for having me, Puya.
Thank you for being with us, and thank you for all the attendees. If anyone has more questions, contact Zara by her account. Thank you so much. I see you.
All right. Bye-bye.